Good afternoon, and welcome back to Health Leaders The Winning Edge program, a series of webinars touching on the topics and strategies that you need to know most. My name is Chris Cheney. I am the CMO editor for Health Leaders and will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Remote Patient Monitoring Success. Thank you to you and our audience for participating. Before we get started, for those of you participating in the live program, I have a few housekeeping details. Note that an on-demand version of this program will be available on your YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right side of your screen. Here we have listed the webinar slide deck and some additional materials for you to download, along with a registration link for future Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our featured panelists for today's discussion. Rebecca Arriaga, VP of Operations at Ochsner Digital Medicine, and Sarah Pletcher, Chief Digital Health Officer, as well as SVP and Executive Medical Director of Strategic Innovation at Houston Methodist. Thank you both for joining us. And with that, let's get into our discussion. First, please tell us a little bit about yourself and your organization. And Rebecca, why don't you start us off?
Sure, absolutely. So I'll start with the organization and then tell you a little bit about myself. So Ochsner Digital Medicine is the chronic disease remote patient management program for Ochsner Health, which, as many of you know, is an 80-year-old health system headquartered here in New Orleans with a footprint all over the Gulf South. Digital medicine in and of itself actually developed as part of our innovation group about 10 years ago. So we've been around for a little more than 10 years and really developed out of a need that our ACO saw of how do we better manage our patients with chronic conditions. So really starting with hypertension and then moving into other chronic conditions such as type 2 diabetes. At this point, we've actually served over 60,000 patients throughout the program in 38 states, in other health systems, other payer groups, and even other employers. So it's been a really great growth that we've seen. For me, I have a background in clinic operations, so really was able to leverage that and move into the innovation space, which I've been in for a little over 10 years, with most of that time being with digital medicine in a number of different roles. So I'm really excited to be able to share some of the insights that we've seen over the years and a little bit about our journey.
Thanks. Sarah?
Well, hi, everyone, and I'll first apologize for my scratchy voice. I'm recovering from a nice spring virus of some sort. Houston Methodist is an award-winning health system. It's part of the Texas Medical Center, which I only learned when coming here that it's the largest medical center in the world. So we have 8 hospitals covering a broad greater Houston area. It's a health system that got its start in a pandemic about 100 years ago and have really battle-tested a grit and resiliency and service orientation, really then leaning in on innovation to really have us as a nationally recognized health system for our patient care and quality. I am the Chief Digital Health Officer. That means that I help to really lead the strategy and clinical design for programs like virtual monitoring, AI, other areas where we are leveraging digital health tools to bring patients and providers and care and data together. So happy to be part of the conversation today.
Excellent. Let's get into our first question. How do you choose the right patients for your RPM program? And Rebecca, why don't you start us off?
Sure. So we actually cast a really wide net. So as I mentioned, we do chronic disease management in the ambulatory space. And as everybody knows, with chronic diseases, you don't actually cure them, right? You may manage them, you may control them, but it's something you always have. So we don't necessarily look for patients who are just out of control or haven't hit a specific target number. Essentially, we say if you have the diagnosis, so do you have hypertension? Do you have diabetes? If so, you're more likely eligible for digital medicine. Now, we do have some exclusionary criteria. So somebody has dementia or somebody has ESRD or is on palliative care or something like that, then digital medicine is more likely than not the best place for you. But other than that, we really try to make sure we're as open as possible so that we can provide that additional level of support for patients. We don't have a graduation portion of the program. So patients can stay in the program for as long as it works for them. We've had some people in the program for as long as the program has existed. We have some people who just come for a short period of time. On average, we have people in the program for roughly 18 to 24 months, but we do have some patients that we lovingly refer to as boomerang patients. So they come in the program, they join, they feel that they have it under control, they get their disease managed, and then they think they can they don't necessarily need the touch bases or the monitoring, and then maybe we're in South Louisiana, right? So a few crawfish boils later, maybe a Mardi Gras season here or there, they do sometimes come back, and we welcome them with open arms and really want the program to fit with patients' lifestyle so we can provide that additional level of support in between visits.
Sarah?
So I wanted to just first give a little bit of framing. In preparing for this talk, we decided we would sort of choose different aspects of monitoring just to give the listeners some perspective. So Rebecca, as you can probably tell, is focusing in on outpatient or home monitoring. So patients who have gone home and who are being monitored for chronic conditions, as she mentioned. I'm going to focus on all the monitoring we do inside the hospital. So again, just to put a little bit of context, Houston Methodist has invested heavily in this space. So we have virtual care cameras in every patient room, every emergency room space across our whole health system. And in terms of monitoring, we offer virtual nursing system-wide, telemetry, virtual sitting. And in terms of devices, we monitor with vital signs, monitoring every patient that comes into our hospitals using a device called BioButton. So it's capturing vitals data automatically for us and being monitored by a central team who then supports the bedside staff. So the answer to the question, how do we select patients, is if you come into one of our hospitals, this is the technology that we use to provide you with excellent care. So by using this system, we have more data, more accurate data, and we are able to allow our bedside team to go in and do manual vitals much less often. So they have more time to care for the patient. Meanwhile, we are actually doing monitoring on higher frequency data. So that's how we select the patients for that program.
And what factors go into patient screening to decide whether they're going to have remote patient monitoring or not? And Rebecca, why don't you start us off again?
Sure. So from a factor perspective, it's really for our program just having the diagnosis. So provided that you have that diagnosis, you're part of the system, that's really the predominant piece that we look at. We, as I mentioned, really do like to cast that wide net so that we can make sure that we're providing that level of care. We've really worked to integrate ourselves within our primary care teams and our specialists. So our cardiologists, our endocrinologists, really have our team provide that support for those patients as the focus factory for those chronic conditions in between their visits with their physician or their provider, really be able to be that constant for those conditions so we can free up some time for the docs to focus on other areas. And so that really lends itself to ensuring that we have that wide net that we can cast.
Sarah?
As I mentioned, we really don't screen the patients in the hospital whether or not they're getting the BioButton. In only very rare scenarios is there a contraindication why we can't place a bio button? So much like a hospital bracelet or a hospital bed, every patient that comes into our hospitals has access to this program and this technology.
Great. What technology do you use in your program? And if you can expand on what you've already said, Sarah, that would be great.
Sure. The program I'm mentioning, it's BioButton. It's a wearable patch or button that just gets placed right on the skin with an adhesive and allows collection of heart rate, respiratory rate, temp, positioning, sleep, activity, some other parameters, and that data flows directly into our monitoring software for us to have alerts and algorithms. And then it also places sets of vitals directly into our electronic medical record. So we spent a lot of time really understanding the market and trying out lots of devices before selecting one that we felt would really be a great foundational support for us to use initially in the hospital, and then to also consider that part of our strategy as we grow towards some of the home-based care programs like the ones Rebecca's sharing.
And what made BioButton stand out as a good technology tool for you?
Well, of course, I think it depends on what your needs are and what you're looking for. And many devices out there sort of fit on a continuum from what we think of as like consumer grade, something you might buy at a gym or buy in Best Buy, and not that those don't have a role, because they can, but then moving all the way over into medical grade or something that you would use in a hospital or a clinic setting where you care about, whether things are FDA approved and whether the parameters are FDA approved. So we knew that for this program, we wanted a medical grade device that was fully FDA validated to be used in the way that we were intending. That narrowed it down quite a bit. We cared about form factor. We needed this to be something that would be comfortable for the patient to wear and be in a hospital and recovering and potentially have wounds and drains, but still be something comfortable to wear. It needed to be easy to apply. We cared about workflow and storage and supply chain. There were a lot of things to consider. We didn't want the patient to have several attachment points. We wanted something that would be an adhesive and wearable to be, again, as convenient for the patient as possible. So those were some of the factors.
Excellent. Rebecca?
Sure. So our program is focused in the home and really want something, we wanted our devices to be easy for the patient to use. So in our program, we have patients that use connected Bluetooth connected blood pressure cuffs and glucometers. We even integrate with some CGMs. All of those devices then integrate with our digital medicine app. So patients will take their readings with those devices and they'll go directly into the app, which will then give them some feedback about that reading. Was it high? Was it not? If it was high, it'll ask them, give them some advice to say, hey, if it's a high blood pressure, for example, wait a few minutes, kind of sit down, make sure you calm down, retake that reading. If it's still high, it'll give them guidance to go ahead and seek emergency care or whatnot. So we use kind of all of those devices together within the program, and then our team looks at that data to then make decisions and understand the trends. From a device choice perspective, again, we really wanted to focus on ease of use for the patient, something that was easily accessible for them. One of the nice things about the devices we use is that the patient actually has to start the reading via the app. So one of the things that actually does is it kind of prevents, like a grandchild or, a friend coming in and seeing someone's blood pressure cuff sitting out and be like, oh, I wonder what my blood pressure is, and just kind of taking it and then skewing that data so their reading doesn't go into the patient's chart as being the reading that they're submitting. So that's a nice kind of safety feature that we have of the devices that we use.
Are there characteristics of a device that might prompt you to look elsewhere or look for an alternative? And Rebecca, why don't you start us off?
Sure. So I think really, for our patients, it's going to be ease of use and the ability to work with kind of different sizes, particularly around the blood pressure cuff. So we really want to make sure that it's as accessible for patients as they can, as it can be. So it's not something that requires, you have to plug it in and then you have to do X and then you have to do Y to take your reading. We want something to be really seamless for the patient. So, hey, it's just part of my routine. I sit down, I spend 5 minutes, I take my reading, whatever it happens to be. So the more complicated it is, the more kind of bells and whistles you have to activate. It actually makes it a little harder to use because then it's something you have to explain to each patient a different way, depending on their level of tech savviness and if they've accidentally activated a feature or not. So really something that's easy to use is one of our predominant areas, as well as simple things like expense and ease of access.
Sarah?
I think I've described the technology that we use and how we chose it. I think I don't have a whole lot more to add on that. We wanted something that was easy to apply, easy to tolerate for the patient, didn't have a bunch of connection points, provided us highly accurate, high frequency data, the companion of monitoring software that we could use to centrally monitor the patients mattered. So along the way, tried out lots of other solutions, and there's all sorts of ways that those didn't meet the bill for what we were looking for.
Great. Next question. How have you developed a budget for your RPM program? And Sarah, why don't you start off first?
So for us, it's not a home monitoring program. It's part of the care that we provide in our hospital. So nevertheless, there still has to be a business case, and to understand the operational costs and benefits. So we don't bill for any monitoring because, as mentioned, it's a hospital program. But we did consider things like staff savings, so being able to give time back to the bedside team. Every time we don't have to have patient care techs wheeling the vitals machine in and out of patient rooms, that's staff and workforce savings that we're able to provide back. We consider all of the patient catches where, because we are monitoring patients in this way, we're catching things earlier and able to intervene earlier. We know that has impact on outcomes, things like length of stay, being able to intervene earlier and reduce a patient's ICU stay. So we consider those benefits as well. So there isn't a payer-based aspect to this program. It's really more of understanding how it fits into us providing the excellence that we want to in the hospital environment.
Rebecca?
Sure. This is always a loaded question, right? It's like the B question, the B word question. So same thing as Sarah mentioned. We really looked at, when this program started, as I mentioned, it spun out of our innovation space. So we were presented with a problem, that we really wanted to be able to care for our patients with chronic conditions within our ACOs better, to be able to help provide more oversight for those patients and also see if we could offload some of that work. So again, same thing. Really looking at what are those kind of operational and clinical areas of return. So number one, are patients in better control in this program than not? Can we get patients there quicker? Can we look at other compliance indicators? And then additionally, looking at what does that do from a time savings perspective for our physicians and our clinical staff. We know that typical primary care doctor has more visits than they can see in a day, more messages than they can see in a day. So if this helps to at least take some of the questions around someone's hypertension or someone's diabetes off the plate for that 10-minute annual visit, they could then talk about something else, whether it be a mental health concern or just, hey, how are you doing? And actually be able to connect on some of the other things rather than some of the more rote management things, which chronic condition management really is.
And how have you worked with payers to gain their support for remote patient monitoring? And Rebecca, why don't you start us off?
Yeah, so I think really the value prop is where we found success with payers, is really being able to look at patients who are in digital medicine compared to those who are not in digital medicine, specifically within our own Ochsner Health ecosystem, and show that those patients who are in digital medicine have a higher control rate than those who aren't, have a lower ED visit rate, have a shorter length of stay, and have a lower propensity to be admitted than those who aren't. So really those value points have allowed us to work with payers and really gain their support for the program and scaling that program with us.
And Sarah?
As I mentioned, we don't work with payers around this program, but again, at a high level, I think it is important to educate payers about all of the different use cases for digital health tools, including inpatient monitoring and outpatient monitoring, so that they have an increased understanding of the value of these technologies, because there is an expense to implementing them and supporting them. And so you do need to partner with all your stakeholders so that they understand the value that they bring to the table.
Great. How have you developed clinical workflows for an RPM program? And Sarah, why don't you start us off?
For this particular program, we already had a team of virtual services in our operations center, including nurses, and we had a virtual ICU program at the time. We were in the process of centralizing telemetry, and so we worked closely with our vendor partner, as well as our virtual team and our bedside team, to develop those workflows with all parties, so that the bedside team understands how the central team is working through this big mass of alerts, to only reach out to them when they have assessed and know that there's reason for concern. We didn't want to just pass a bunch of alert and signal noise to the busy bedside team, and so the central team really works through those alerts and then escalates and communicates that information following workflows and algorithms that we've developed and refined together. And then as the program has evolved, the technology has gotten better, the algorithms have gotten more refined, so we continue to develop those workflows in partnership with our, as I said, with our stakeholders, the bedside, the central monitoring team, and our technology partner.
And how does that centralized team vet alerts to decide which ones to pass along to the bedside care team?
It's a team-based approach. So we have monitoring techs, nurses, ICU nurses, even moving up to APPs and physicians. So sometimes it is based on the alert type, how it escalates, but they're using their judgment to assess the patient. They have access to the EMR, they have access to the trending data for that patient. They have the ability even to camera into the room because of our virtual care highway to interact with the patient and see what's going on. They can chat directly with the patient's nurse, to find out what's going on. So it is a combination of having algorithms and protocols, but also using clinical judgment and working in partnership with the bedside team.
Great. Rebecca?
Yeah, so digital medicine really functions like a focus factory, which has been great because our team really just works on the clinical best practices for our chronic conditions. And with that, we've really been able to develop like a brain trust. So we have our medical director and our clinical leads who really focus on what are the most current guidelines, what are those recent best practice guidelines that we can implement within our practice model. And then we also have a roundtable of other specialists that we can consult with, whether it be primary care doctors, cardiologists, endocrinologists, to make sure that they buy in and they're on board with those different best practice guidelines so that everyone's really on the same page and working in that focus battery setting.
And how do you stay on top of best practices and what best practices should be applied in your RPM program?
So for us, it's a labor of love, right? We have people who really do stay on top of that literature and are, all the time saying, hey, this is the most recent thing that's come out around how to manage hypertension, how to manage diabetes, how to manage other chronic conditions, kind of best in class, most recent guidelines. Sometimes we're the ones who are saying, hey, everyone, this new, protocol is, what's recommended or whatnot. This is how we're going to update our guidelines. And we share those with the remainder of the system, so everybody's really using that same approach. But to your point, it is a labor of love. It is something that is not, hey, it's easily, you get an email on Monday and like, these are the things you need to update. It's, here's some new research, here's some new guidelines that have come out. This is how we want to incorporate this. This is how we want to implement it for our new patients, for our established patients, and how that works going forward, but then also how we apply it retroactively to people who have already been in the program to make sure they get those alerts and those tasks completed for them as well.
And what's the difference between implementing these best practices for new patients versus established patients?
Yeah, so I think what we've seen is, from a new patient perspective, you can say, okay, for every new patient, we're going to get XYZ lab value. And when they come in, you just go ahead and order it. But let's say somebody's been in the program for 5 years. And 5 years ago, that wasn't our current standard, or even 6 months ago, that wasn't our standard. How do we say of those patients who have been in the program who don't have that lab value drawn yet, or don't have that lab value within whatever the last 3 months, 6 months? How do we make sure we identify the subset of those patients and also reach out to them so that we're able to apply those best practices across the board and not just as a new practice guideline or recommendation comes out, not just to those who enroll or we interact with post that recommendation.
What about established patients?
Same thing. So we would go ahead and essentially pull a report or look through our established patient panels and identify patients who meet those criteria that, hey, they really needed XYZ, again, lab value done or something like that. And then we would go ahead and make sure that we that we have them on a list so that they also get that same interaction from our team and we have that same data point to include in our management for best practice management of those patients.
Great. So how do you secure clinical buy-in? The clinician teams, the frontline teams for your RPM programs. And Rebecca, why don't you start off?
Sure. So digital medicine, as I mentioned, functions like a focus factory. So we're a team within Ochsner Health, but we don't sit in each clinic. We're a remote team. So with that being said, one of the main things that I think everyone who's done change management on here knows is communication, right? That's one of our biggest areas of buy-in, making sure that everybody knows about the program, making sure that we're routinely interfacing with the clinics, kind of boots on the ground clinic teams, whether it's the providers or their staff, to make sure they're aware of digital medicine, to make sure if they have any questions on what our protocols are, how we're interfacing with patients, how we're interfacing with their patients. So communication has really been one of the predominant components. One of the second pieces to that is that kind of brain trust focus factory that I mentioned. As I mentioned, we do work on, developing what our best practice guidelines are to make sure that we have that guide our care, but we don't do that in a vacuum. As we develop that, we use those representatives and draw on those representatives from the other areas, primary care, cardiology, endocrinology, in essentially our clinical roundtable to make sure that, yes, everyone is in lockstep. This is what we want to do, and this is how we're going to move forward. Finally, from an ongoing practice perspective, we do have clinical roundtables. So we have representatives from those areas where we, like a traditional roundtable, right? You bring a challenging case, you bring a case where you want additional information, or you just kind of bring updates and whatnot so that everybody really is on the same page and we don't do anything that people have not heard about or surprising or could be seen as not being partners in this. One of the big areas that digital medicine really focuses on is that we are part of the care team. We are not the only people on the care team. We really are helping to augment that care team that the patient has. We have one of our physicians who actually describes it really great. She essentially describes herself as the quarterback. She's Dr. Smith, the quarterback, and she has all different people on her team, and special teams and offense and defense. We love our Saints here. We love our football analogies, but she really has described digital medicine as one of those people who are on her special teams, and that she wants her patients to participate in that so that they can, play well. So it really is, the emphasis of communication and getting that buy-in across the board.
Great, Carol?
Yeah, and unfortunately, there isn't a super exciting, sizzly answer. It just is, you just have to do it. You have to communicate, communicate, communicate. And if you think you've communicated too much, you probably need to communicate some more. And it can be hard to thread that needle, and that people sort of are tired of you talking about the same topic, but at the same time, they'll tell you, well, why didn't I hear about ABC? So just as an example for this particular program, although it really interfaces primarily with nursing, it was important to get out and talk to every physician group I could think of so that they were aware what this meant, especially as we began to do vitals redesign, right? In many of our hospital units, our staff was doing manual vitals every 4 hours, and in moving to every 6 and every 8, and even out to every 12, it was important to make sure that all of the stakeholders understood why we were doing that, were reassured that that was safe for the patient, allowed the bedside team more time to provide the kind of care we all wanted them to, allowed the patients more rest and recovery, which they appreciated, and really gave the physicians and nursing staff and everyone involved an opportunity to hear and understand how the technology works. And even now, several years after rollout, when it's completely at scale, we still have to make sure that which can be hard, right? I think, we're so happy when we get things rolled out that it can be easy to sort of forget that you still have to go back out and re-educate and hit the talking points and dispel any myths that may have come up along the way. So yeah, no substitute for just communication across the nation.
And you're working with inpatient care teams. How are you communicating the value and the safety of your RPM efforts with those care teams?
I think, first you educate them on the market and the technology and how you chose what you chose, and you share with them the rigor of FDA approval and validation process. They get to see the technology and see how it works and understand the accuracy themselves. So that's a piece of it, is just bringing them into some knowledge about how you selected it. You have to start with the why, like, why are we doing this? And explaining to them that you value their role in care and trying to get them out of having to do rote and repetitive activities when you can instead direct them into providing care at the top of their license and giving the patient more rest. So I think sharing the why is really helpful. I think those are two of the two key areas, is just getting them up to speed on what you're using. And then I think the other thing is that we will often start a new initiative in a selected group of units that are ones where they're used to trying new things. And so that can be a really valuable source of input and making course adjustments, to then have them help us spread the message to their colleagues and peers about, here's how this works. It's really easy to learn how to put the button on. This is great. My patients are getting more rest. You sort of build a coalition in that way.
Great. Go ahead. Did somebody have something to say? We'll move on.
Oh, I'm sorry. I thought there was some audio feedback. I thought you were redirecting me.
No, I think we can move on to the next topic. What are your benchmarks for a successful program? And Rebecca, why don't you start us off?
Sure. So we really look at success in 3 ways. So one, as I mentioned, first and foremost, we developed as a clinical program, and clinical benchmarks, clinical success are really kind of the first thing that we look at. That's, we're here for patient care, we're here for patient safety. So we want to make sure that our clinical benchmarks are measured, well, and show that digital medicine patients are doing well. So some of the things that we look at there include control rates. They also include, as I mentioned, some lab compliance rates and different things like that. We're actually looking at kind of creating our own, in digital medicine, we like to be innovative, kind of true to our roots, kind of creating our own score called an optimal care score, looking at care on the hypertension and diabetes side specifically. And really, it's kind of an amalgamation of different things. It includes things like control rates, compliance with different lab values, the actual lab values in and of themselves, looking at that information just to get a little more multidimensional view of patient progress in the program rather than just looking at control. In addition to clinical metrics, we also look at engagement. So, we are a remote patient management program. With that being said, we do get readings from patients at home. So are they submitting them? Are they participating? What does that look like? So really want to make sure patients are engaging with us through whether it be readings or interacting with our team, whether that be through live telephone discussions or my chart messages. As we know, some people prefer to talk on the phone and some people would rather you never call them and send them a my chart message. So we make sure that we work closely with the patient to determine what method of communication works best for them. But we also track engagement in that way. And finally, patient satisfaction is one of the things that we look at. So every year we do a Net Promoter Survey or an NPS survey, and really excited that we have been exceptional every year with scores ranging from high 70s to low 80s. So, really seeing that as digital medicine continues to evolve, as we have different flavors of the program, patients still on the whole really enjoy it. And, that really does help us kind of with that continuum of happy patients go into good clinical control rates, goes into good satisfaction, and really creates that cycle.
Great, Sarah.
So as Rebecca is monitoring individual patients with specific goals and therefore frames the benchmarks accordingly. Because our program is across all of our hospitals, we're looking at it more from a broad population perspective, but also monitoring, the health of the program. So we certainly consider things like how many patients have we monitored, right? And track that over time. On an ongoing basis, we're looking at, compliance utilization. So are we missing patients that somehow don't get a button or lose their button? We're looking at things like loss rate, to really partner with our nursing units and supply chain leaders to make sure that we're not losing too many of these small buttons. From a patient perspective, we look from a research intent across the broad population of patients since going live with this program to make sure that we're continuing to see outcomes, length of stay, mortality going in the right direction. We pay attention to how many alerts the team processes, how quickly they respond to those alerts, how many alerts get escalated all the way to the bedside. We track great catches to really understand specific patient stories where using this technology, we know we were able to intervene earlier. So there's a lot to considering the overall program, but those are some of the things that we pay attention to.
And I know this may not be a good fit for you, Sarah, but I'm interested in what you have to say about it. What data are you collecting, and how does that data reflect a return on investment from these RPM programs? And Rebecca, why don't you start us off?
Sure. So as I mentioned, we probably see the best way to prove ROI from a clinical data perspective. So again, looking at things like control rates. As you know, from a HEDIS perspective, we are all predominantly judged on HEDIS every year for large swaths of our patients. So what does that HEDIS outcome look like? And helping that goes into proving ROI. Some of the other direct ROI areas that we look at are, again, looking at patient expense. So we see that we have an overall decrease in ER utilization, decrease in inpatient utilization, which leads to savings specifically for our ACO and shared savings patients. So really looking at those types of clinical indicators to help drive an ROI, in addition to just the individual patient stories that you hear that are more feel-good ROIs. But again, every time you get that patient testimonial or you hear that kind of really positive patient story, it really helps put some of the numbers in context. The numbers are great, and the numbers certainly help us make the business case. But when you get it down to the patient level, that really helps to color that business case.
And Sarah?
Yeah, I think the data points that I mentioned, we collect a lot of data points to really monitor this program. I mean, all of our innovation projects and programs, especially the ones that we've taken out to full scale, there's a business case and an ROI on all of them. I think for the BioButton project, just simply understanding the time savings, as I mentioned earlier, that we're giving back to the staff. So purely from a workforce time savings perspective, we can speak to that part of the business case. If we then consider the implications in quality and safety and catching things earlier for patients, you can consider that as part of the ROI as well. But lots of data. And yes, we are always trying to be sure that we can see and measure the impact of all of these investment areas.
And you say catching things early for patients. And what are some examples of how the BioButton is allowing you to intervene earlier on patients and improve clinical outcomes?
Well, so if you think about it, previously, if the nurse was going into, we're not talking about the ICU, right? We're talking about a typical med-surg hospital room. If the nurse is going in maybe every 4 or every 6 hours, we don't know what might be happening with that patient in between those intervals when someone is going into the room. With a BioButton on, those pieces of information are being collected every minute and then being flowed into monitoring software so that we know sooner when there is trending, whether it's the heart rate is changing rapidly or the respiratory rate is changing, as might suggest the patient is developing sepsis. So there's a million examples. We've caught heart arrhythmias, even for patients who are on traditional telemetry, because there's a central team, there's algorithms that don't ignore when they start to see trends and changes in patients. So those are some of the ways. Again, also by using protocols and algorithms and a team-based approach, we're able to do things like have our rapid response team, instead of only waiting for times when the bedside calls them to come and see a patient they're concerned about, they are also part of this loop. So if the trending data on a patient suggests something might be developing, the rapid response team can go and check in on that patient, even over virtual sometimes, to start to take some action a little earlier than they could have if they'd waited for that patient to deteriorate until someone decides, okay, now we need to kind of come and assess that patient. So everything from sepsis to respiratory distress to heart arrhythmias. We've had instances where a patient is bleeding out or having hemorrhage around the heart. Again, a million examples. And it just really goes to show you the power of having high frequency data paired with analytics and algorithms, with central monitoring teams, and then partnered with a great bedside team that now has time to go and do more meaningful assessments of patients, because they aren't just chained to the monotony of wheeling the vitals cart in and out of rooms.
Excellent. What factors go into scaling an RPM program? And Sarah, why don't you start us off?
I mean, first, I think as we've talked about together, and Rebecca, I know will say the same thing, you really need to have your coalition. You have to have people understand the why. You have to have educated and communicated to your key stakeholder groups. There's still a lot of change management, and so you really have to address change management with the usual tools of persistence and communication and celebrating small wins and building your coalition and finding your champions and winning over your critics and the like. Project management, again, I know it's a boring topic, but really having project management chops so that you can implement and copy paste, to roll this out over and over again and get more and more efficient each time you do it. Those are definitely some of the factors, and having a leadership team that is really sold on the importance of this and comes together. So for this project, having unified physician leadership, executive commitment at the hospital CEO level, having our CNOs and our system nurse executive get on the same page about why we were doing this, to really partner on the vitals redesign. It really is, it takes a village, a large village, to get these things out to scale. And you've got to have a solution that works and at a cost point that you can defend with a business case. So it's not going to go anywhere or stay out there unless those things are in place.
Rebecca?
Sarah took all my answers. Yes. So I think one of the pieces really is, this is the perfect example of it's not what you know, it's who you know, right? So you need to make sure that you have that large coalition, that you have kind of all of that buy-in from the typical players, whether it be at the clinical level, the executive level, but also in some of the support areas, right? Who in the IS team is going to really help you scale this? How do you make sure that they are bought into what are all the different pieces you need, and why are all the kind of, wonky reports where, someone's like, do you really need to see this? Yes, this is why, and let me tell you why it's important. So really making sure kind of that education spans across those different levels, really having friends in the legal and compliance area so that if something comes up, if someone asks a question, you're not re-educating every time. You have somebody who knows what is your new and innovative solution and how does it work, so they can really help give that advice. One of the other things, and this is going to sound a little contradictory, is really being able to formalize the scrappy, because normally these RPM solutions or these types of things are, hey, wouldn't it be cool if? And then when you start to scale, you're really kind of having to put in the infrastructure for what you did in a really scrappy way. So there's one piece that you have to say, hey, this is the process and this is what we're doing. But at the same time, you still have to be really comfortable with the gray. I know I say this all the time, and if people who talk to me every day had a quarter for every time I'd say it, we'd all be billionaires, but we're building the plane as we fly it. So we're really looking at, new technologies coming out, regulations are changing, and you really have to be able to say, hey, this is the process that we're putting in, this is how we're scaling it, but something a little innovative and a little cooler or, and more effective is out there. So let's see how we kind of peel back this little piece and put in a new piece to make sure that what we're implementing is really the best thing, and we're continuing to move forward, not just take the solution that we have stuck in time, but continue to iterate on that while you continue to grow it.
Excellent. I think I have time for one more question before we go to the Q&A. What has surprised you, good or bad, about your RPM strategy? And Sarah, why don't you start us off?
Oh, I was going to kick that one over to Rebecca first. What has surprised me? This is a kind of, I guess, nerd clinical answer, but I'll just pick on one. So, BioButton measures respiratory rate, and it measures respiratory rate by actually counting the movement of the chest wall. So it's highly accurate. And although I knew that our legacy approach to counting respiratory rate was not terribly accurate, right? Everyone sort of just has their Gestalt favorite number that they tend to fill in. I've still been surprised to see how different and variable and dynamic actual respiratory rate is, and how important a predictor respiratory rate is of changes in the patient. So I think that has been just an interesting surprise from a clinical perspective, and has resulted in us having to do some education about what real respiratory rate variability looks like. And I think we're just scratching the surface of of learning more surprises about trending vitals data now that we have this high frequency continuous flow as a way to better catch things with patients. So that's sort of a clinical surprise, I guess.
So you would say trending vitals data has been more accurate and effective with the bio button?
Well, I was mentioning respiratory rate as just one specific example because that's tended to be a subjective, someone goes in and, in theory, eyeball counts the patient's respirations. So that one in particular, when you're actually measuring the chest wall movement, is definitely more accurate. And because we're doing it with higher frequency, we're learning about that variability. I think we've known for some time the power of continuous physiologic monitoring in the ICU, right? Because that's how we look after patients in the ICU. So this project is really bringing some of that ICU level data frequency into an inpatient setting, which has been the innovation. And to do it in a cost-effective, convenient, non-invasive way.
Rebecca?
Well, I had a little time to think about it. So thank you for going first, Sarah. So I think from my perspective, one of the most surprising aspects has actually been some of the feedback that we've received through our NPS scores throughout the year. So as all of us who are in hospital operations or, kind of healthcare know, most of the time patients really only take the time to write feedback if they're not happy. You usually don't get the happy feedback. And we've seen that about 90 to 95% of the feedback we get is positive. And it's not about the really cool tech stuff we're doing, right? It's not that, hey, we can get your readings from home, we can call you and change your meds over, we can call you and say, hey, this looks like it's trending up. We really need to change XYZ to this medication, or we need you to go in for a lab. It's really none of that patients talk about. It is the relationships with our team. It's, hey, I feel like I have somebody behind me. I feel like I have somebody else in my corner who really wants to listen to me, who really wants to help me with this condition that I've been struggling with, whether it be for my whole life or I was just diagnosed in it. So I think for me, it's really that we have all these really cool tech forward programs that we're working on, that we're integrating. But at the end of the day, that connection in healthcare, the human connection really does weave through. And even if it is a tech forward program, the importance of that is still very pronounced and makes a difference on patients. So I think that's really kind of the most surprising piece to me, is that regardless of how cool your technology is, which some of it is really cool, and that respiratory rate thing sounds amazing, there's still that piece of, there's that nurse on the other end, right, looking at that. Or for our side, there's a health coach or a clinician who's looking at those values and really digesting it and explaining it to the patient and managing it in a way that works for them.
Yeah, I think I would agree on the connection point. And even though I should know by now how powerful the why story is, again, there's still the surprise there each time that carries the weight that it does. And again, a million examples along the way, but explaining this to patients, and some just focused on the, oh, great, you're not going to come bug me, I can sleep. Others, it was like, oh, great, I can watch my show, or my family's visiting and you aren't going to come in. But for some, it was oh, well, now when I'm alone in my room, which even at the best hospital with the best care, they're still going to spend some time alone in their room and probably scared about how they're feeling and how they're doing. So to hear the patients express that, well, now when I'm alone in the room, I still know that your team is looking out for me and is keeping an eye on me. And to hear the same thing from the bedside staff. Well, now when I'm in room 3, I'm always, tied up with something going on with that patient. I always worry about what could be happening with patients in the other rooms. So to hear the staff and the patient both feel like this technology and using central teams brings us all and keeps us all together, it's been fun to see how that why carries all the parties forward, when what would otherwise be a, you want me to do what? You want me to put that on my chest, might otherwise seem a bit scary.
Excellent. let's move to the Q&A portion of the program. First, I want to thank you both for an excellent discussion. It's been fascinating. This now brings us to the Q&A portion of the program. So we would now like to invite you and the audience to ask live questions of our panelists. As a reminder, if you are participating in the live program, to submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by other audience members. I'm going to wait for questions to come in. I don't see any in the list right now. So a question that I'd like to put to both of you. If there were one or two key takeaways from this discussion that you would like the audience to have, what would those be? And Rebecca, why don't you go first?
Boy, hot seat. I think, one of the things we both focused on is that communication is key. When you're introducing these programs, when you're scaling these programs, really building that coalition, really making sure that at all levels you have communication, or you're keeping everybody in the loop. Communicate. What is it? Communicate. I think that's probably, one of my key takeaways. I think the other is kind of what we talked about just right at the end. I think Sarah said it great, the why. Really, as you're thinking through this, especially in healthcare, we really are, working with the patient. So being able to contextualize the why and have a good why for patients. Because what we're doing is really cool, but it is different. And it is something that patients come to us at a level of vulnerability. So being able to explain that, I think, is also a key important piece.
Sarah?
Yeah, I think the why, I think the other thing I sometimes remind on the why is we mostly know we need to bring out the why when we're speaking to the direct stakeholders, the patient, the physicians, the nursing staff. But we don't always remember that when we get further away from that with other stakeholders, especially when we might be having we just need a brief thing from them, right? You're going to the facilities person to ask for a bracket that you need to install your hub for your BioButton device. And, it's a relatively straightforward ask, but taking the moment to say, do you know about this project or why we're doing it? Oh, it only takes a minute, but it's nice for the guy making the bracket you need for your widget box to know why they're making the bracket for the widget box. And so I think, at the beginning of meetings to just ask the question, hey, is anybody on here not really know much about this project and need a minute? I've almost never had someone not say, I'd love to just get a little bit of overview. So it's not just remembering the why, it's not forgetting that everyone may want to hear it again. I think that part's been a takeaway. I think the other thing is I'll sometimes speak with hospitals or health systems wanting to get involved in some of these projects, and they get overwhelmed by maybe how large we are or how mature the program is now. And it's a good thing to just point out that you can still start small. You absolutely can start small. The key to being able to do anything to scale is to still have a big plan, but just to break it into phases and start somewhere. So I think that would be the other takeaway is don't be afraid to get started and start small. Just have a plan for how you will take it to a bigger or more scaled place.
We're almost out of time, but there's one question here for Sarah that I hope we can get to. Considering where we're at now, where would you like to see the technology go from here, from a clinical perspective?
So if by technology you mean specifically this project, obviously, I'd love to see it used in more areas of care. We're looking to try to put more enabling technology and programs on the patient as they go home, with home monitoring and post-discharge. I think in general, I'm looking for technology to be smaller, cheaper, better, faster, more seamless to enable more convenience and comfort for patients to allow them to be home when they can be home. when patients are in the hospital to allow us all to spend less time doing paperwork and documentation and manual repetitive stuff, and more focused on working out what's wrong with the patient and advancing their care plan and showing them compassion and connecting everyone. So yeah, like everyone else, I'm excited about where it's going, but we have to be mindful of designing the programs to keep our broader mission and vision in mind.
Excellent. That's all the time we have for questions today. In closing, please note that our next Winning Edge program on May 5 will cover the Winning Edge for expanding your virtual nursing program. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week for continued coverage on strategies for achieving remote patient monitoring success by visiting our website, healthleadersmedia.com.